after we conclude this webinar, your PTR will serve as our attendance for this activity. Thank you po. We start in a few minutes.
So, hello, good morning. So, I'm Dr. Lawrence Manalili from the Department of Rehabilitation Medicine. So, for today, I'll be discussing the therapeutic updates on physiatry for shoulder and knee pain. So, for my outline for this morning is first to discuss what is the next step after undergoing physical therapy for both shoulder pain and knee osteoarthritis. Second, what are the challenges specifically in the rehab department of our hospital in catering to osteoarthritis patients? Then third, what are the relatively new and offered interventions for osteoarthritis at our hospital? And fourth, this is to discuss the interventions for the frozen shoulder in our hospital. Because as we have checked our census, a staggering 30 to 40% of our MSK and osteoarthritis patients are already from our own staff. So meaning our own nurses, doctors, ancillaries, and the other stakeholders of our hospital either have problems in their MSK, musculoskeletal system, mainly their shoulder, and also are experiencing knee pain in the form of arthritis. So now, we are now trying to navigate the frontiers of healthcare. So we are trying to explore the innovations in medicine because relatively, um, the Philippines or specifically our patient in Quirino Memorial Medical Center are trying to avail of our services because we are trying to shift the context of rehabilitation. So we are a very reactive and rehabilitative approach. So now in the advent of the universal healthcare, we are trying to be a little bit more proactive and preventive. And also, we are trying to offer more non-surgical management for osteoarthritis. So, non-surgical management in the form of injections, aspirations, aside from our standard of management in the form of client education, lifestyle changes. Okay, so we are trying to explore the breakthroughs and challenges for knee osteoarthritis. So, first and foremost is the lack of information, which I'm sure most of our medical staff have been dealing with since QMMC has been established. So technically for osteoarthritis, osteo or katandaan, as most of our patients would call them, are always attributed to age and degenerative changes. So always there is lack of prevention and primary health intervention. So you can see there are already so many infographics thanks to our public health unit and also thanks to our EHS and to our family medicine colleagues. They are trying to improve the information delivery and information dissemination to our stakeholders regarding osteoarthritis and its primary management. Next, for the minimally invasive procedures, once you say osteoarthritis to a patient, they always say, Doc, for opera na ba ako? Or Doc, ayaw ko kasing magpapalit ng tuhod or ayaw kong magpalagay ng bakal sa katawan. Okay lang na masakit or okay lang na ganito ako maglakad, basta wag lang ako mapa-operahan. Okay? So what we are trying to do in rehabilitation medicine is to preserve the function and mobility of our patient to the point that they don't need surgery anymore. So we are trying to prevent the total knee replacement and to improve the quality of life of our patient. So one, aside from our health instructions, we always offer physical therapy and referrals and lifestyle modifications and a change in the environment of our patients para hindi naman sila mahirapan. But now, in our department, we are already starting to offer the minimally invasive procedures in the form of joint aspirations if in case of there are already so much bursitis, so much fluid inside the joint, and also to inject new orthobiologics. Previously, always offered steroid injections for any form of arthritis. However, in the field of rehabilitation medicine, we have already seen the detrimental effects of chronic steroid injections, both for the joints, the cartilage, and at the osseous structures. So we are now trying to shy away from chronic steroid injections. In the advent of the development of medicine, so we already in our armament two two injectates, one in the form of hyaluronic acid and the other in the form of orthobiologic, which we call the platelet-rich plasma, which I will be discussing a little more in depth later. Okay, next, another problem for osteoarthritis is the inadequate pain control. So most of our patients or most of our staff here in the hospital will have a significant decrease in their activity and in their performance of their duty because of the pain. So technically, it's a downward spiral. So if there's more pain, then you will lessen your activity, therefore weakening more your supportive muscles and the structures needed to prevent your degradation of the muscles. So technically, a decrease in mobility will further lead to more pain. So if you've seen our elderly patients and our obese patients, they are starting to walk like penguins. They're starting to waddle because that's the cycle and the the negative cycle of pain. Okay, so recently, around 2018, 2019, the NICE guidelines has been developed for the multimodal management of pain, wherein just started to give the anti-neuropathic pain medications for osteoarthritis. Previously, we just started giving paracetamol, your tramadol, your celecoxib, your naproxen, your NSAIDs. But now they have already identified there's a small aspect or there's a more small component of neuropathic pain. So for our other colleagues, especially in the intermedicine and all of the EHS, you can start giving your anti-neuropathic pain in the form of your gabapentin or your pregabalin if you already have some history of neuropathic pain in your osteoarthritis patients. So, as I was saying, what is the future of interventional procedures in the realm of physiatry or rehabilitation medicine? So, as I said, platelet-rich plasma is a biologic therapy that uses the patient's own blood to treat a variety of conditions. These include injuries to bones, tendons, ligaments, and also the joints and the cartilage. So it's an autologous, meaning there is actually no medication that is to be injected into the patient. It's literally the patient's own blood, ranging from around 13 ml to as much as 50 ml of blood is drawn per procedure. Then it's processed in the form of a centrifuge machine. Then the layer that is important is the one that is injected to the patient's injury. On the other hand, hyaluronic acid is naturally found in the body, so it's high molecular weight and it's found in the joints, the eyes, and the skin. And it can help lubricate and improve the shock absorption of the injured joints. So these are two injectates that we put inside the knee to help decrease the pain, improve mobility, and improve the function of our patients. So, what is platelet-rich plasma? As I said, it's a part of the blood with at least twice the concentration of platelet compared to the regular plasma. As I said, it's also an autologous process. And how is it prepared? It's prepared by centrifuging the blood and separating the layers where the highest concentration of platelets and growth factors. So here, first step is withdraw the blood and place it in a tube. Next is to centrifuge the blood sample. Then, as you can see in the third photo, you can see at least 50%, 55% of the whole blood, the least dense. Then at the middle is the buffy coat with the leukocytes and the plates and the platelets. It's less than 1%. And at the bottom, the red part, are the erythrocytes. So it's 45% of the whole blood, and it's the most dense layer. Actually, what we need is the less than 1%. So it's around the buffy coat and also the bottom left picture you can see the platelet layer. So if we're going to inject it, it's just around 3 ml. So as you draw from a patient, so 13.5 ml of blood is drawn, and you will yield at least 3 ml of platelet-rich plasma, which then we can inject to any pathology in the body. But in our case, we're addressing the osteoarthritis or the cartilage injury for our patients. So as I said, you get for the so here on the left side, you can see that the blood hasn't settled yet. Then on the right side, you can see the clear yellow. So this is how we aspirate and separate the layer, which is important for our procedure. So technically, when do we inject hyaluronic acid and when do we inject platelet-rich plasma in patients who have osteoarthritis? So we start the management at the Kellgren-Lawrence 2 and 3. So for all levels or for all grades of osteoarthritis, we always have lifestyle change, regular exercise, physical therapy, and analgesics. It's across the board. You always provide that in the holistic management of osteoarthritis. Then for Kellgren-Lawrence 2, you can give your patients platelet-rich plasma. So for the regimen in preventing total knee replacement in the next 5 years would be at least 3 doses of platelet-rich plasma injection for each knee, at least 2 weeks apart, 3 sessions per year, then a minimum of 3 years. So at least 3 years, you get your knees injected with platelet-rich plasma to decrease the need for a total knee replacement in the next 5 years. Okay, next, moving on to Kellgren-Lawrence 3. So again, lifestyle change, regular exercise, physical therapy, analgesics. Then if there's already significant thinning of the cartilage and there's already significant joint effusion, first we can give hyaluronic acid to coat the remaining cartilage, decrease the inflammatory markers, and decrease the infusion, the bursitis. Then we inject our platelet-rich plasma. So again, the regimen for platelet-rich plasma is still 3 doses, 2 weeks apart, then at least 3 years. However, for hyaluronic acid, it's a little bit different because hyaluronic acid gets degraded as time goes by. So at least we have two types of hyaluronic acid. You have your high molecular weight, highly cross-linked, which is a one-shot hyaluronic acid injection, which can last for as long as 6 months up to as long as 1 year. Then for the other side would be the high molecular weight, then medium cross-link. It's a little bit less. So sometimes 3 months, kasakit na agad yung tuhod. Sometimes up to 6 months, pwede na. It depends on the profile of the patient. However, if it's already Kellgren-Lawrence 4, wherein the patient already has a non-existent joint space, the cartilage is also eroded across all the different articular surfaces, then hyaluronic acid and platelet-rich plasma will benefit your patient minimally. Okay, because they are already destroyed articular surfaces, and there is nothing the platelet-rich plasma will try to regenerate or to heal. So in that case, rehabilitation medicine cannot give the 100% return to mobility and decrease in pain. And for that, we already refer to our colleagues at the orthopedic department to do the total knee replacement. Okay, so as much as possible, we want to catch our patients earlier, preferably at the KL1, Kellgren-Lawrence 1, 2, or 3. And we don't want them to progress to Kellgren-Lawrence 4. Okay, so the question is, can we inject already orthobiologics for Kellgren-Lawrence 4 after a total knee replacement? The answer is no, because it's already a metallic implant and there are already no cartilage for inside the joint space. So that's it for the management of osteoarthritis. I think some of the nurses in our hospital already underwent the procedure in our department. So what we did was we already injected the hyaluronic acid in their knees to decrease the pain, improve their mobility, and also for them to better perform their task. This is specifically intended for those who are one in the intensive do who does a lot of walking, standing. So mostly our NAs, our aides, and our nurses. So next, we are going to discuss about the current landscape for tendon tears and frozen shoulder. So there are a number of our colleagues suffering from a painful shoulder. So either one, you only have two things. Either you have a beginning frozen shoulder, or you already have a damaged shoulder, a damaged rotator cuff, or you already have a tendon tear. So in the conservative management for tendon tears and frozen shoulder, it's always analgesics, physical therapy, home exercises, and of course, modification of the work environment because we have to prevent further injuries. Okay. However, for frozen shoulder, what was done in the past was steroid injection. So technically, we use a very quite long needle to inject inside the shoulder joint and to infiltrate the joint capsule with steroid and some analgesics. So these are some factors to consider prior to management of shoulder pain, either a tear or frozen shoulder. First, how big is the tendon there? So there are four tendons that are very important in the rotator cuff and the shoulder. So these are the supraspinatus tendon, the subscapularis tendon, the teres minor tendon, and the long head of the biceps tendon. There is mine. Okay, so technically, if these tendons are just partially torn, partial thickness tear, then we can do the same procedure as the platelet-rich plasma to infiltrate and inject and try to heal the gap between the tears. However, if the tendon is completely torn 100%, then there's already tendon retraction and there's already atrophy of the said muscle, then the injection will have little to no benefit anymore. Then again, we have to refer to our orthopedic surgeons for the operative management. Okay, next for comorbidities. So a number of our patients and our staff already have some form of or a level of diabetes. So technically, diabetes and some immune diseases slow down tissue repair and because of the medications they are taken. So specifically aspirin, clopidogrel, or heparin, and the antiplatelets, they slow down or decrease the level of platelet activity, therefore minimizing or reducing the effectivity of platelet-rich plasma injections and therapies. Next would be the level of activity. So, for example, we have a patient that is already around 70 or 80 years old. Then you found out that the patient already has a partial thickness tear of the supraspinatus tendon with difficulty in raising the right upper extremity and the shoulder. Also, you found out that the patient is bedbound and dependent in all aspects of daily living and has already been bedbound for more than 5 years. So with that in mind, you will already not offer the procedure because it has minimal to no benefit because the patient's mobility and the patient's function is already minimal. However, if you have a relatively young patient in the early 30s or 40s, active in the hospital, so does a lot of lifting, that does a lot of overhead activities, play some sports. Then you found out that the patient has a partial thickness tear of the supraspinatus tendon. Then you can offer your platelet-rich plasma as an adjunct to your physical therapy, your analgesics, and also your lifestyle modification. So another part in doing the procedures, as I've said, for the knee and the shoulder, is do we do it landmark guided or do we do it ultrasound guided? So in our department, in the Department of Rehabilitation Medicine, we are doing both. Okay, so if you want to inject something and we are already we are already versed in doing the injections via landmark, we can effectively deliver the injectate into the anatomic structure, whether it's the joint, it's a tissue, it's a ligament, or a tendon, we can do it both, either landmark guided or ultrasound guided. However, thanks to our management and thanks to the family medicine, we're able to borrow and to use the ultrasound machine at the OPD. So here are just some studies to help drive across the point that ultrasound guided procedures are already safe and is already the standard in doing soft tissue injections. Okay, so if you want to be more academic about it, know the exact figures. This is the article for you. So on the leftmost, you have your palpation on based on a cadaver. Then on the middle, you have your palpation clinical. Then you on the rightmost, you have your ultrasound guided procedure basis and success rates based on the different joints. So as you can see from the glenohumeral, the first row, you can see that on palpation, it's a bit wide, from 10% to 100% of the injectate at the time. So at least it's a very big margin. However, if you do the injection ultrasound guided, you are assured at least 97% of the time that your injectate will reach the proper structure, in this case, the glenohumeral joint. So as you go along down, you can see there are more convincing numbers. For the knee, it's 75% to 100%. You are assured that you are already inside the knee joint or the suprapatellar bursa to properly deliver your injectate. So here, these are just some samples of what we do in the department. So these are some of my patients that I've done the ultrasound and I've done the injection and the assessment on our patients. So for the left side of your screen, you will see that this is the long axis view of the supraspinatus tendon, and we are trying to check if we can see and reach the intended structure. So the first video is an assessment of how well the tendon moves. And you can see that there's already some fluid inside subacromial space, and that's our target. So in the video at the bottom, you can see from the left side, there's a white line piercing the tendon, and there's a flash of white. That's technically the injectate reaching the tendon there. So this patient had a partial thickness tear of the supraspinatus tendon and has been complaining of chronic shoulder pain and is already starting to develop some frozen shoulder symptoms. So this just goes to show you how well and how accurate the ultrasound injection is. By the way, the target is as a very thin 1 to 2 millimeter line, and that's the tear. So here are some take-home points from today's discussion. So first and foremost, exercise is medicine. If you've been to our department, we always say that you have to continue your home exercise. Rehabilitation is not just about physical therapy. It's not just about changing how your body works. It's always doing your habit and forming a good foundation of movement for your body. Okay? So I cannot stress that exercise is medicine. Then again, for the second point, ultrasound guided interventions are safe and effective, and that is what we've been doing in the department to better improve our clinical outcomes for our patients because adequate visualization and the needle path placement are the basis for effectively delivering the medication to the intended pathology. So, for our department, there are already a number of doctors offering these procedures, both for our patients in the outpatient department and also our colleagues at the hospital. So again, this has been a quick update on what we do in the department, what we can offer you, and what are your options in managing your patients with one shoulder tears or knee osteoarthritis. So again, thank you for your time and attention, and happy happy weekend.
Thank you, Dr. Manalili, for that very informative lecture. We will now be opening the floor to questions. So if you guys have questions, please type them in the chat box and we'll be glad to forward them to Dr. Manalili. Um, to start things off, as a matter of curiosity, Doc, if we have a patient who will qualify for say PRP, how much will that set them back in terms of cost? Po?
Okay, so that's a very important clinical question for our patients. So for our outpatient setting, we are currently uh, forcing the medication request through the malasakit or through the MSS. Okay, so fortunately, the hyaluronic acid in syringe and the injection is available at the malasakit center. However, they have to the usual process: a medical certificate, your RX pad, then the quotation from the different providers of the hyaluronic acid, then the interview with the different providers. Then once they have the medication, they just go to us. Then we just do the procedure at our clinic. Roughly speaking, if a patient is going to buy the hyaluronic acid injection from a company or from any source, it will set them back roughly around 20 to 25,000. Okay, it's expensive. That's why we course most of our patients, and if not all of our patients, through through the our MSS. So the same goes for platelet-rich plasma. Again, it's a bit expensive. That's why we always force them to our social service because one kit of platelet-rich plasma, one injection kit, costs the same around 20 to 25,000. And it's already up to the jurisdiction of the doctor and the physiatrist what to inject and when to inject and how much to inject. That's where in the art and science of rehabilitation comes into play. Okay. So we actually have done numerous patients at our department who have already received the medication and the injection kits from our social service. So what they do, they consult us, we offer the procedure, then we give them the necessary documents. They process the documents and then just schedule for us. Roughly speaking, it takes an average of around 3 weeks, sometimes up to 6 weeks, for them to get or procure the medications. Okay. Hopefully, I was able to answer your question about that, Paula.
Yes, sir. Question, follow up to that. If, for example, we have our patient injected with that, is there a downtime? How long is the downtime kung meron po?
Okay, so for hyaluronic acid injection for the knee, there is no downtime. Literally, once you inject the medication inside your knee joint, you can do everything. You can start working. If it's, kung meron kang shift ng 2 to 10, pupunta ka sa amin ng morning para mag-inject, you can already start working in the afternoon shift. Because what hyaluronic acid does, it's like a change oil for your knees. However, the same cannot be said for platelet-rich plasma. Okay, so technically, a downtime is intended for those playing high-level sports. For example, if you're a basketball player or if you are into high-intensity sports like wrestling, mountain climbing, there's a downtime because technically what we will do is we will induce a small level of inflammatory process inside the injured structure. So if it's a tendon, then the tendon will get brittle a little bit because it's going to be inflamed for at least 2 to 3 days. Okay, so that's just the downtime for your platelet-rich plasma injection. 2 to 3 days, minimal physical activity, then up to 3 weeks of limited explosive activities. So if you're going to play basketball, then you have to you have to mellow down a little bit. Okay. However, for the platelet injection for the knee, the same goes. So 2 to 3 days, minimal physical activity, meaning you just do your regular work. You can walk, you can drive, you can do your uh, basic activities. However, if you want to play basketball, you want to go swimming, or you want to play badminton, then it's not allowed because, again, of the minor inflammatory reaction during the first 6 weeks. Okay, I hope I was able to answer your question.
Yeah, sir. Yeah. We actually have a question from the audience. They'd like to know if should we expect any side effects when we have our patients do PRP?
Okay, so for the most common side effect, because it's still an injection, would be pain, specifically at the injection site. Okay, so aside from pain and swelling, there are very few um, side effects that you have to monitor. So one of the most common side effect would be a full-blown inflammatory reaction, meaning that the joint, specifically the knee, because of the many eroded cartilage, you will expect to be full and quite painful, but it will just last for around 2 to 3 days. That's the good thing about the platelet-rich plasma injection because it's an autologous procedure, meaning allergies, walang nangyayari kasi it's your own blood. Okay? However, there are some patients who are very much afraid of pain. So they ask, Doc, can you put analgesics or can you put anesthesia in my or on my knee prior to the procedure? It's up to the patient. Okay. Some patients they want one injection because the injection of the platelet-rich plasma takes less than 5 seconds. It's literally like a vaccine for your shoulder. They identify the area, clean it, then do the injection. We can see the needle inside the joint. We can visualize the medication going inside the joint space and pull out the needle within 5 seconds. It's that fast. Okay. So another other form of side effect would be the fullness because we are injecting around 4 ml or 3 ml into a joint space. If your joint space is not distended, meaning there's no joint fluid, there's no effusion, you will feel fullness and you have some restriction in doing your knee flexion or bending your knee. But that side effect usually goes away after 3 to 4 hours. Okay, so hopefully I was able to allay your fears with this kind of procedure.
May question pa sir sa ano to. It reads, gaano daw po katagal ang effect ng injection and kailangan daw po ba ng follow-up injections?
Okay, so that's another good question if you have first timers. So it really much depends on the level of pathology of your patients. For the platelet-rich plasma, as I mentioned, for Kellgren-Lawrence 2 and 3, gaano katagal? It's going to give you at least a minimum of 3 years. So 3 doses every year for at least 3 years. Okay? This is just a top up. You still have to do your exercises, your physical therapy, your lifestyle modification, and yung pinakamahirap kasi yung diet. Okay? So, gaano katagal? It really depends. Some patients, they feel already a significant relief after 2 injections. Sometimes nga isa lang. However, yung clinical improvement mo is not always correlated to the anatomical improvement. Sometimes baliktad. Pag tiningnan namin yung tuhod, oh grabe, sirang-sira na yung tuhod mo. Actually, uh, candidate ka na agad for knee replacement, pero hindi naman ganun kasakit yung tuhod, then you can still offer the procedure. Okay? So, gaano katagal? The platelets, they work based on the literature. If you inject it, they work immediately. Then how long? Up to literature based is up to 1 year. So, marami ka makikita na gino-offer na the platelet, they work up to 1 year inside your joint. Yes, that's correct. However, it's not always it will work 100%. Meaning there's still some level of activity based on the physiology of the knee joint. However, hindi siya 100%. Okay? So sometimes, less than 1 year, yung effect niya. However, for hyaluronic acid, it's a little bit different because hyaluronic acid, it literally gets degraded. Parang makina lang ng engine oil mo yan. Kahit anong gawin mo, gamitin mo o hindi, kailangan mong palitan yung engine oil. That's also for the knee. Hyaluronic acid gets degraded, bumababa, napipit-pit din siya, then it gets reabsorbed inside your knee joint, so you have to top it up. So, based on literature, 6 months yung pinapromise ng lahat ng hyaluronic acid injections, yung kanilang minimum effectivity, and you have to top it up after every 6 months. However, some patients, maganda yung kanilang outcome. They do their exercises, then they are very good in their diet, and they are able to change how they do things or their work. Tumatagal ng 1 year, 2 years yung kanilang hyaluronic acid injection. Okay? Then for the shoulder, once you do your injection for a partial thickness tear, it will depend again on the level of activity. So sometimes one dose, pwede na, tatagal na yun ng 1 year. However, you still have to do your stretches, you still have to watch how you do your work and how you do your activities. Okay? So again, yung sinasabi ko, yung platelet-rich plasma and hyaluronic acid, this is not a magic pill. It's not a magic bullet which will solve all your problems in the knee and the shoulder. It's always an adjunct. So para yung triangle, yung pyramid kanina, nasa tip lang siya. You have your foundations na dapat lagi mong gagawin para mas maging effective yung ating management. Okay?
All right, thank you, sir. Follow up po sa ano to. What precautions, are there specific precautions that we should give our patients who have underwent procedures po?
Okay, so that's also a very good question, specifically for those taking numerous medications prior to the procedure. So since we are dealing with pain, most of our patients are taking anti-inflammatories in the form of your NSAIDs or your COX-2 inhibitors. So there's a certain washout period. So prior to a platelet-rich plasma injection, at least 7 days, you want to stop all your NSAIDs. Okay, so you stop your naproxen, your ibuprofen, then also your COX-2, your celecoxib, your eterocoxib prior to procedure. However, if your patient already has some form of antiplatelets or platelet inhibitors in the form of your aspirin or your clopidogrel or your enoxaparin, you have to get a clearance first from your cardio or from your internal medicine to the procedure because as again we want to stop the aspirin, clopidogrel, enoxaparin at least 7 days for the washout. However, if your patient's safety profile does not allow it, meaning your patient literally has to take these medications, then we can do the procedure. However, there's a downside to it. The procedure will not be as effective compared to a control procedure, meaning those patients not taking any form of antiplatelet. So if you have two patients who underwent the procedure, there's a significant lower, as much as 20 to 25% concentration and platelet activity for those who have either aspirin, clopidogrel, or your enoxaparin. Okay? But still, your patient's safety is tantamount. If they cannot stop the medication, we can still do the procedure, although to a decreased effectivity to an extent. Okay. Other precaution would be steroids. Okay. So if your patient is already undergoing chronic steroid therapy, either in the form of oral medication, intravenous, or in the form of your cough medication, it also applies to the rule. If it's a safety profile issue, then you continue the medication. However, you can expect a lower effectivity of the injection. And if your patient already underwent a prior procedure in the form of an injection of the joint with either your cortisone, your triamcinolone, your methylprednisone, you have a 1 month washout period. Okay, meaning you cannot do a platelet-rich injection in a joint or a structure that has been injected with a steroid in the last 30 days. Okay, so hopefully I was able to answer your question regarding medications and precautions prior to these procedures.
All right, Doc. Thank you. Last question. So there's this question that says, the demographics of patients who have shoulder and knee pain seem to be getting younger. So, the question is, what can we advise our patients and relatives who suffer from this condition?
Okay, so that's quite an updated question because again, based on our epidemiology in the department, usually we get our knee pain and shoulder pain in the 50s. Okay. However, in the advent of the pandemic, working conditions has uh, changed drastically. So it already predisposes our patient for chronic shoulder pain because again because of the ergonomics. So most of us are already in front of our laptops, if not our tablets, cell phones, or any form of desktop, which predisposes you to a shoulder impingement and a further tear in your shoulder. Okay, so the advice is still the same. Do your physical activity if kaya. Then, ang ginagawa na lang namin ngayon talaga is to tailor our management that you can do it in front of a computer. Dati kasi you have to go out, you have to exercise, you have to play a sport, you have to walk. However, in the confines of our office work or in the confines of our work environment, hindi na kaya. So yung exercises na tinuturo namin, actually ngayon, naka-base na nang nakaupo ka. Kaya mo nang gawin yung exercises ng nakaupo, both for your neck, your shoulder, and your knee. Because as our patients are getting younger, meaning they have a longer time to damage, repair, and re-damage and re-injure those structures, meaning they are more predisposed to early onset arthritis. Okay? And we know the challenges ng nangyayari sa atin. Almost all of us do not have the energy to work out or to have a sport or to exercise. Because again, tatak QMMC, we give it our all pag nasa trabaho. Okay? So before, pagpasok, you already pagod. Pagdating sa work, you do your best. Then pagdating mo sa bahay, after all the commute, pagod ka na rin. So ang tinuturo na lang namin are just a few exercises, namely a few stretches that you can do under 5 minutes. Okay? To prevent at least or mitigate the risk factors for you developing a shoulder pain or knee pain. Okay? But then when it comes to our in mga metabolic syndromes, kailangan natin talaga yung ating cardio. Okay? There is no replacement for a good walk. So previously 10,000 steps ang ating sinasabi para ma-reach mo yung minimum physical activity to prevent any lifestyle diseases. However, now, pwede natin ibaba yung actual number na yun to 6,000 as long as you're able to reach a designated heart rate. Meaning, you can walk fewer steps as long as you are feeling a bit tired. Bilisan mo lang yung paglalakad mo, pawisan ka lang ng onte, ma-feel mo lang yung increase ng heart rate mo, then that 10,000 steps, kaya mo ibaba ng 6,000 steps in a day. Okay? So for our nurses, I'm sure lagpas-lagpas 10,000 steps na yung nagagawa nila. However, you have to take care or to cool down after your work. Okay? The same goes for our MAs and all those who have a lot of walking done in the hospital. Okay? I was able to answer that question from our from one of the audiences.
I believe so. I believe so, sir. Yes.
Mm-hmm.
All right. So thank you, Doc Lawrence, for sharing your time, your expertise with all of us here, for all of us attendees. So with that, I would like to remind everybody to please complete the PPR for today's institutional conference. The link is posted in the chat box na po. This will serve as your attendance. So should you have any more questions or suffer from any of these problems, you can always visit us po sa department. Salamat! You guys have a good Halloween weekend.